All right, thank you, everyone. Please let me know if you cannot hear me or there's any problems with the audiovisual. Um, so I'm going to talk very briefly about what seems like a fairly simple problem, but is something that has significant public health implications. Title of this is Ambiguous Assaults and Accidents, ICD-10 Miscoding and Firearm Injuries. So here's some of the disclaimers. I do a lot of work in the firearm injury and violence prevention space on the local level here, including programs for patients. And this is an outgrowth of that in terms of understanding our local epidemiology, data structure, and reporting capacity. Firearm injury is a problem. It is a substantial cause of death in the United States, and this is something that is quite specific to the United States compared to other developed countries in the world. However, as big of a problem this is, in fact, it has recently become the leading cause of death for those under 20 years of age. Um, this is something that's still not well understood or researched compared to other leading causes of death in the US. And so part of this stems from a lack of really quality data when it comes to understanding mechanisms and intent of injury as it relates to firearms specifically. And so really at the core of it is a simple thing. Um, while firearm injuries are a mandatory report in the sense of describing that this had happened for potentially future investigation, the actual ways in which we understand firearm injury tend to come from two data sources. They're either from these trauma registries, ED registries, or from insurance data, i.e. claims data, ICD-10 codes. That said, the coding, when it changed from ICD-9 to ICD-10, carried over a problem with how we talk about intent of assault injury, especially as it relates to firearms. So here is an example of something from our institution where a patient came in with a GSW or gunshot wound. And this was described, patient had a GSW of unknown etiology, reported a penetrating wound to the right pelvic region, pressure applied, pale, diaphoretic, and hypotensive. So these are all pretty bad things. This patient is quite ill. And the clinician, when they're trying to code from an ICD-10 perspective, what the reason for this injury is, has a couple of different options. So I want you to think about if you were, say, the emergency department physician or the trauma surgeon seeing this patient, would you say that the reason for this gunshot wound is something that's accidental in nature, unintentional, indescribable, or unknown, or an assault injury? Without much further context, it can be hard to say. But let's say that the patient were to tell you, oh, um, I was walking along outside and then I felt a pain and I heard a gunshot and I was shot in the pelvis. Would that change your specificity of classification? Is that accidental because you don't know if they were the intended victim, right? And that moment of ambiguity actually leads to nationally unstable estimates in the rates of firearm injury and the reasons behind it. Ironically, if that patient were to die, there is a clearer vetting process as outlined by the CDC right here as to then how to classify that. And according to the CDC recommendations for ICD-10 classification, if that patient were to die, this should be clearly associated as an assault. Even if the patient said, I was walking outside, I didn't know what happened, and I was shot. And the reason is because the definitions for unintentional, right, i.e. accidental injury, these W codes, as you can see here, is more strict, right? It has to be something where it was clearly unintentional, like you were cleaning your gun or someone was cleaning their gun and the gun accidentally, unintentionally went off and then you were injured. Um, if it was I was out wrong place, wrong time, as it said, and injured, that should be classified as assault unless you could clearly identify it another way. And again, these criteria more strictly apply to death data, but if the person doesn't die, then it is more ambiguous. And part of the consequence of this is then we see this reflected in databases. And so national databases such as the National Trauma Data Bank, or some of these other validated ones where they have trained coders and abstractors going through these charts, you see the general reporting of firearm injuries in the US approximately being 75 to 80% assault related, of all gunshot injury types. If you just look at ED data though, such as the NEDS database, the leftmost bar there, it's more ambiguous, right? And where it looks like it's only 43% assault, but in more recent investigations into this coding anomalies or these coding issues, we find that a lot of those that are initially described as accidental are probably assault according to that stricter definition. Right? It's just that there isn't a manual abstraction or a further investigation process in place to vet that, because most people who are injured by firearms actually survive. And so when you look at this statistics, maybe 20% of those that are gunshot injuries, especially by suspected assault, those might be serious enough to end with death or with a trauma activation, but many do not. And then so it sounds like a simple thing. It sounds like a straightforward thing, but what it has led to is this actual real lack of insight into what individual case volumes are for their traumatic injuries, particularly by firearm. And so looking at our institutional data at Christiana and going over a couple years, we find that it seems like overwhelmingly we have a lot of accidental injuries from gunshot wounds. And while looking at national data, we may say, well, this is probably inaccurate. It's unclear. For example, we have a number of rural areas within the state, even and across the United States. And so it's possible that accidental injuries really are different in terms of their prevalence based on geographic area. And so it may not necessarily be fair to assume that there's an 80% distribution of assaults for these ICD-10 coded firearm injuries that initially appear accidental or unintentional. And so what we did was we did a retrospective chart review of a sample of patients in the year 2021, so post-pandemic. This is important because in 2020 there was essentially nationwide surge in firearm injury that was also experienced locally here, and this was historically high in 2020. And so we wanted to take a look at the slice of things essentially post that period. And we looked at these records, and we looked at it using a chart abstraction methodology that was more similar to the way that the CDC recommends classifying fatal injury from firearms. And we said, okay, what are the different categories that this should fall into? Assault, accidental, suicidal, from legal intervention, or truly unknown, where there's no data at all related to what the etiology could have been behind the shooting. And kind of the rule of thumb is unless it was really obviously accidental, it tends towards defaulting to assault injury if it's not clearly suicidal legal intervention. And so here is kind of a combination of these results. So on the right side, and highlighted in the blue, again, are those national database findings. The second bar there with the big orange is what was actually documented locally here, where the majority are in this other or ambiguous category. And then after our chart abstraction, the leftmost bar is what we found, right? Which is that our firearm injuries, generally speaking, match our national database of vetted descriptions of the rate of what firearm injuries intent is, which is, again, assault. When we dive deeper into this, many of these patients who were classified as true assault were in fact discharged from the emergency department, which helps us hone into where the sources of this ICD coding ambiguity or misclassification come from. And when we dig further into who is doing the documentation behind this, we find that if they're in the emergency department for acute injury, it typically starts with the emergency clinicians assigning the ICD code, and then this tends to carry forward then to discharge. And so of these that we reviewed, 81% were reclassified as assault injury, and 59% of those were discharged from the emergency department. And of all of these charts for these GSWs coming in, over 90% had that first indication of intent from when they hit the emergency department, and again was carried forward. And the reason why this is helpful for us is that we can then focus our intervention efforts in trying to improve the ICD coding around the emergency department staffing. So that way we're getting those patients that are discharged from the ED for low acuity injuries that may not see the trauma service, where they have more detailed evaluation and perhaps more accurate coding related to trauma registry or other databases. And then as we dug further into this, we realized that when you interface with the EMR, we use Cerner currently, and you type in gunshot as a clinician looking for a diagnostic code, we find that the default one that pops up is actually the ICD code that lines up with accidental injury. And so when we started talking with the clinicians, the ED doctors, the trauma surgeons, and others, they had no idea that what they were putting into in the EMR was defaulting to assessment as an accidental injury in terms of intent. They thought, oh, I picked the most ambiguous code here because we weren't sure, and we just thought gunshot wound is a gunshot wound. And so as we kind of dug further into this, recognizing our limitations, we realized that when we look at this coding and we look at this ambiguity that's there, that part of the issue relates to how this backend process goes from taking a natural language um, uh, description of the GSW, gunshot injury, and its translation into it. And what we found is that for Cerner products, on the back end, this mapping process between what people type in for GSW or gunshot wound, and then how it identifies and suggests eligible lists of ICD codes happens through this company, Intelligent Medical Objects. And so there's some facilitation that's going on here, and it's kind of a black box. We don't actually know how it crosswalks or maps the sort of natural language query that clinicians are putting in and how it's kind of steered or suggested towards specific ICD codes. This is probably actually more significant than we have previously given credit to, because when I talked with some of the researchers who had been doing this detailed work looking at ICD coding nationally, they found that they expected the miscoding or error rate in ICD intent to be maybe 20% or 30%, whereas at our institution we found it was like 80%, 90% were inaccurately coded. And they said that doesn't make sense. And when we were digging deeper into it, they said, well, actually, almost all the healthcare systems we're working with, looking at this, they all use Epic. And so it makes me wonder if some of this discrepancy in what we observe in what is assigned is really because of this back-end interface that's going on here. And then it makes me wonder how much of this is going on related to other ICD coding phenomenon. And it just kind of, again, highlights the caution that needs to be held when we start looking at things from an ICD perspective. And so I know I'm at or over time in terms of 10 minutes for talking about it, but just to highlight for you then, when we think through how can we improve our coding and improve the quality of our data that's there, because most studies that look at firearm injury or assault injuries start with the ICD codes, especially when they're trying to get at ED-related data and then work their way backwards. First, we wanted to validate and say, yes, our local statistics likely match the national statistics, and so we can do an imputation of that from a sensitivity analysis perspective. But then we can also say, hey, how do we do essentially coding education and guidance, and who should we focus on? And so actually our coding and documentation team has been really supportive of this and came up with internal guidance to say, here is really how we should begin, and we should look at classifying things. Here are the sources that validate this approach to say, yes, we should be classifying it in this way, and how can clinicians do a bit better to help us with our infrastructure moving forward. And in fact, this afternoon, we'll be having a conversation with the ED resident staff and launching our own quality intervention program to help with this ICD coding, and hopefully we'll have more to report to you from there. So I'm going to stop there and say I apologize for talking quickly and kind of moving through this fast, but this is a project we've been working on, and we're grateful to INBRE, which has supported this in multiple ways. First, through a data voucher, where we were first identifying this issue, looking at Medicaid data specifically, and then through a data science pilot itself. Next steps that we would be looking at is actually developing a common data model that can take into account this likelihood of miscoding to help other healthcare systems that are trying to begin to understand their own local epidemiology as it relates to firearm and gunshot related injury, as to what is the likely patterns there. We would love to be able to apply natural language processing as well, but in the absence of those kind of more sophisticated tools, just a simple thing like this goes a long way in helping us understand our local patterns better. So, what questions do people have for me?